to another Sydney Neonatal Lectures. Today it is my great pleasure to introduce Dr. Erica Jacobson. He's a pediatric neurosurgeon from the Sydney Children's sort of area in the Randwick Hospital. And she's going to talk about something which we don't always encounter, actually every now and then encounter, and every time you have to think about it. So the abnormal neonatal head shape, craniosynostosis, and plagiocephaly. So Erica, over to you.
Look, thank you very much for that introduction. I really appreciate being invited, Kurt. So thank you as well for everybody. And I've tried to direct this towards you guys. And exactly as Kurt just said, have I started my video? I'm going to start my video. Have you got my video? Can you see my... I'm going to go back.
Recording in progress.
Can you see everything? I'm not sure. I'm going to keep going. Please ring if you have any.
Yeah, I can see it well. Thanks.
Excellent. Thanks. So I've tried to direct it to you guys. I've got to start my video in the center of my screen. So anyway, that's okay. Do you have start my video in the center of your screen? Because I do.
No, I don't. But...
That's okay. Good. As long as you can see everything, that's great. Yeah. So you guys really, as neonatologists, you get to see a variety of head shapes, and kids come out with all kinds of weird looking skulls and things, and it's seeding out for you which ones are going to be things that maybe have caused significant issues for a patient as they grow, or which ones are just going to get better. And the vast majority of things that you see are things that just get better. So you get quite significant, I wish I could get rid of this thing. You see quite significant issues with birth. And of course, that's really obvious. You know, you get birth deformities, you get terrible things like caput, you can get to other things like cephalhematoma, such as this kid in the left. And these can, in some children, quite quickly calcify. And I saw a child who had a cephalhematoma that had been soft 1 week. And by the time I saw it, you could already, within a week, and this kid was by this stage 4 weeks old, could feel the bone creeping up the sides of the cephalhematoma to calcify, and within another week it was fully calcified. So it's pretty phenomenal. And
well, Erica, if you want to get rid of that video message, probably just turn on your video, or if you have one.
I don't know whether I
have a video. It's on the bottom, start video. On the bottom.
I'm going to start video.
There you go. Yeah, now the message should, now the message should be gone, I hope.
It is gone. It's all good. Thank you very much. So you do see some really bad cephalhematomas. Like the image right down the bottom center of your screen is someone who's got these great Mickey Mouse ears from cephalhematomas. And we've definitely had a child like this. Her mother basically disguised it sort of by, she had quite wild hair, the mother had wild hair, and she disguised it by sort of having great big pigtails. But this kid literally looked like they had Mickey Mouse ears on their head. And while so they don't always go away, things like cephalhematomas, but they're very, very benign. You see the occasional bad ping pong fracture from forceps deliveries, and these usually in a small child will expand out and blow out without any form of treatment. So you can get a variety of these things, whether it's a caput, whether it's cephalhematoma or a subgaleal hematoma, and it's unusual for us to see significant injuries like extradurals after birth. So we see all kinds of odd-shaped heads in infancy, and the vast majority of them are benign, but some of these are less benign, and some of them are just from deformation. So I'm going to go over deformational. What I'll go over is development of the skull, all the head shapes that we tend to see with those, deformational shapes, and craniosynostosis, and things to look out for in this vein. So the development of the skull is slower than the brain. So we know that it's designed for birth, and we need to have a baby who has a head that is very well designed to deform their skull and come out easily. As I said, that starts developing well after the brain. So neural development tends to start by about 2.5 weeks of age, and you've got your full complement of neurons. Even if the brain hasn't myelinated or anything till 2 years, you've got the full complement of neurons by 28, 30 weeks. So pretty much things are set in stone for how the brain's going to start going at that point in time. And between 8 weeks and 30 weeks, you have a lot of neural migration and a lot of folding of the brain. Now, the skull doesn't really start before 6 weeks, and that's really the base of skull only. And you're not really getting good old skull development until 20 weeks development. So if you get kids who are 24 weeks, 25 weeks, they've got thin, soft skulls that are easily deformed. So the developing skull, there are 3 parts to the developing skull, and they all form from slightly different ways. The basicranium, which forms all the base of skull, is a mesodermally based tissue. It forms from cartilage, and the bone forms within cartilage, so it forms little solid cartilage knots, and within that the bone centers form. And then you get cartilage joints, which are quite rigid. So the base of skull is designed to be a nice rigid base on which everything else develops. Neurocranium, which is most of your skull, the convexity, that comes from the neural crest. So it's very different origin, and it forms within membranes. So instead of forming within cartilage, you've got 2 membranes, and that becomes dura and periosteum in later life, and the bone forms between those. And you don't start really forming good bone centers till about 16 weeks of age. And as you know, you've still got incomplete formation when they're born. And most of the sutural closure occurs well into childhood and adulthood. Now, the viscerocranium, which is your facial skeleton, is also neural crest origin, but it forms in a mixed way, but your sutures remain open till all the way through childhood. So that makes sense, because we see people develop from cute little babies to ugly adults, and that's all that facial development that often happens between the ages of about 7 to 8 and puberty. And certainly that's very important as far as craniofacial work goes, because you can't do anything to fix the face if they've got deformity until they're old enough and that's matured enough for you to work with it, because you'll cause all kinds of weird deformities. And you certainly need to have all of your teeth down to be able to do it, so you don't bugger up all the roots of the teeth. That was a technical term, everybody. So the neurocranium, as I said, develops in between a membrane, and that dura, it's initially just a neural membrane and develops into dura. It's dura first, and it's very expansile, and that allows the brain to expand, of course, but it's also tethered. And one of the reasons why you get a C-shaped brain, so the frontal lobe rolls around into the C shape of the temporal lobe, it's because you get tethering of the dura to the base of skull, and it pulls everything round into shape. Otherwise, you'd end up with these bloated round brains with big holy ventricles in the middle. So the dura is very important in shaping the brain as it forms. And as I said before, it tends to form little centers. So you have dura with little centers of bone at each point. So you get a center in one frontal bone, a center in the opposite, same with the parietal, same with the occiput. And you get right in the center, and then you get radial formation of bone out towards what will be eventually the sutures. So these will eventually join up and become sutural joints. So in a fetal skull, as shown below, you can see the radial pattern of the way the skull forms. So you can see that's a lovely demonstration of the parietal bone having those lovely striations of radial bone formation. So it's possible to sometimes see these things prenatally if you see a craniofacial problem, but it's really unusual. And you really need to have very good ultrasonography where you can have good facial imaging, 3D imaging, or where you can easily see a sagittal synostosis. But it's really super unusual for me to see a patient with a diagnosis of a craniosynostosis, even the very severe ones, antenatally or prenatally. It's usually nearly always antenatally. And is it really important to know early? Well, probably not, because while you can theoretically, and some people have done intrauterine surgery, that bone grows. And even when you've just been born, and you have a sagittal synostosis operated on, you can take a whole lot of bone of the skull off at 6 weeks of age, and will have grown back completely by 6 weeks of age. So intrauterine surgery is probably not going to be a prospect for this sort of thing. So postnatal skull development is what we're really looking at. And as we've said, designed for birth, but it's designed also to expand. So the skull expands very quickly with brain development, has to do it with in the first 2 years in particular. So while this shows that the skull is adult size by 65% of adult size by 1 year, it's 85%, getting on for 90 by 2 years. So that progression through childhood, it slows down and it keeps going, but it's really, your head is quite big by the time you get to 2 years of age. So I think I did that measurement from here. This the 98th centile on this chart is 53.5 for a boy at 2 years, and adult 98th centile is 58.5, and that works out to be just under 90%. And nearly most of once you get to that 2 years of age, and once you get past all of that, it often starts, particularly in, from the age of 10 through to about 20, skull growth is mostly about skull thickness and not about anything to do with brain growth at all. And it shouldn't be anything to do with brain growth after about 2 years of age, really. Postnatal development, of course, the sutures mostly close really in adulthood. Sagittal suture closes earliest, but you definitely see them open. In most skulls, you'll still be able to see sagittal coronal lambdoid sutures and the parietal squamosal sutures on a dry skull. You don't see the metopic suture. It's the only one that disappears. It disappears in the vast majority of people by 9 months of age. And of course, on an adult skull, you just don't see it, whereas you see it on all those pictures of little babies, fetal skulls. And that's important because a suture that closes early ridges, and that means when the metopic suture closes, it causes a ridge, and I'll mention this later. And so you will often see quite a normal metopic ridge because it has closed. If you see it in any of the other sutures, it's far too early. So the head shapes we see are wild and varied, and they're usually very diagnostic. So looking at all of these, there is a whole series of head shapes that are described in terms of cephales or cephales. They have specific shapes associated with them, and they're very often associated with specific conditions. So the wonderful thing about deformational and plagiocephaly and craneosinostosis is that you can diagnose nearly all of these children without any imaging at all. So brachycephaly and plagiocephaly. So brachycephaly is a flat head at the back. Plagiocephaly is an asymmetrical head. They're very common deformational shape changes. Whereas scaphocephaly is very much associated with sagittal synostosis. And about 95% of the kids who have a scaphocephaly will have a sagittal synostosis. Trigonocephaly is usually associated with metopic, or always associated with metopic synostosis. You don't see it in anything else. And the rhomboidal shaped plagiocephalies, where you've got an asymmetrical head, but not in a parallelogram fashion, are going to be lambdoid or unicoronal synostoses. And you get the other forms with more complex fusions. And the only one you tend to get just from birth is oxycephaly, where you get that pharaoh-shaped head of the deformation as a child's come down the canal. So I think of examination of these kids essentially as orthopedic: look, feel, move, X-ray. So we're looking at bones, so it makes sense. It's not quite the same as joints, but it follows the same pattern. So you want to first look from all angles. And if you look at all heads from all angles, you should be able to see some interesting features. So you can see, if you look from above, you can see a triangular head like the picture in the middle. You can see the parallelogram plagiocephalies versus the other plagiocephalies that are much more rhomboidal, so it's shorter on one side than the other. You want to look for this at the side. You want to see where the vertex is, a very anterior vertex, where the top of the head is in front of the ear and gives you a very bullet-shaped head, is very typical of sagittal synostosis. Kids with brachycephaly can be very flat, or bilateral coronal synostoses can be very flat. You want to look at the front and back. So if you're looking at above, side, front and back, you want to look for facial asymmetries, which can be very common in things like unicoronal synostoses. And lambdoid synostosis is often associated with a very asymmetrical skull base. So you have one side lower than the other. Then you want to feel for ridges, and the really obvious one you will see most commonly will be a sagittal synostosis. And I think this is the sort of synostosis you're more likely to see as neonatologists, as it's the most common of our single suture synostoses. And if you see a kid with a long, thin head, and you palpate the sagittal suture, it's really obvious when it's ridged. So all ridges, e.g. the normal metopic fusion are fusions. You can get dips. So if you have abnormal hollowings, that can also be indicative of problems. So for example, at the back of the head, you know, the normal back of the head will grow outwards, and you should get the occipital bones low down growing outwards. If the occipital bone low is indented, that's a bit of concern, can be associated with a lambdoid synostosis. You do, as the head grows backwards, of course, where the sutures are, often get dips. So I've got one thing that I call the dent of improvement, which we see in kids with deformation or brachycephaly, where they're growing out, the occipit's growing up, and just above it, where the bregma should be, where the lambda is, you can get a dent. And that's a normal indication of normal growth of the head. So move. So we're not going to do the same thing as we do with joints in the hand or in the elbow or at the wrist, but you can blot sutures. So if you have a kid with a long, thin head, it could just be positional. But if you can't feel a ridged sagittal suture, but you can push on the two parietal bones and you can move them, that's going to be an unfused suture. So when they're very young, you can still move the sutures around a bit and tell if there is a fusion or not. And of course, then you do need to sometimes image. Now, usually, as I said, you can diagnose these without anything, but some kids have really odd head shapes and there's something going on, and you guys will ultrasound very quickly. That's a great thing because it will show if something's really abnormal in the head. And this is a kid of mine who was born, the image on the right at least is the x-ray of this child, born to a family where 3 of their other children had already died in infancy at about 6 months, as this child eventually did. And this kid had Walker-Warburg syndrome, a very, very recessive condition, and very poorly developed, very scrambled cerebellar development as he got older, and died by 6 months of age. So ultrasound and MRI are very useful for diagnosing those head shapes where there is something really wrong with the brain underneath. And usually it's going to be more like hydrocephalus than anything else, but you do occasionally get these odd things. So deformational plagiocephaly is directly relevant to you guys because you're at the forefront of these kids developing deformational plagiocephaly, because you see the kids with very soft, small heads. And there has clearly been improvement in kids' head shapes and neonatal care over the time I've been alive. So deformational plagiocephaly is very culturally based. You know, there are definitely cultures that wrap heads and make a long, thin head. And certainly the Pharaohs, I think the bottom skull is from the Huns, but the Pharaohs did the same sort of thing where they would try and make a head long and thin. And this was done by wrapping heads. The picture on the right are prisoners in South America, and there is a significant number of people in this picture with quite severe brachycephaly. And you do find culturally there are some ethnic groups that have far more brachycephaly than average, and these are the people who now we currently do, who wrap their children up tightly and lie them on their back when they're neonates. And of course, we're doing that in the Back to Sleep program. There's also some cultural differences just across places like Europe. So the cephalic index is just a measure of how oval your head is, and it's one that we use regularly, often to see how kids are getting better when they've got a brachycephaly, making sure their cephalic index is going down. It's a measure of the lateral diameter of your head over the AP diameter of your head, and shows how oval your head is. So if it's too oval, it's too long and thin, you've got a scaphocephaly. If it's too squat and flat, you've got a brachycephaly. But there's clear differences. This is from a journal, I think one of the main journals in the late 19th century, and it shows the cephalic index in Northern Europe is significantly different from the cephalic index in Southern Europe. So Swedes have nice, long, thin, ovally heads, and by the time you get down to the Balkans, they've got very flat heads. And we all know this. I don't know, I've got an uncle who comes from Croatia, and he's got this immensely flat head, and all of his mates do too. And so it certainly gets flatter as you go down towards the Balkans from the north. And of course, as I said, we get them nowadays. We get flat heads from the Back to Sleep program. It's very typical to see heads like this on the left from lying flat on your back. And also the kids who will turn their head or can't turn their head properly and can only lie on one side or favor one side, possibly because that's how they were in utero, get asymmetrical heads by lying on one side. So this is a really common finding. Deformation occurs in a significant number of patients. Years ago, I read a great article from New Zealand where they measured heads throughout the hospital in little kids, and they found about 20% of kids by the age of 4 months had some degree of deformational problem, either brachycephaly or plagiocephaly. Another recent study in Canada showed 46% of kids at around 3 months had significant malformations of the head. The vast majority of these, of course, are pretty mild, but it means it's really common. And even when I look at CT scans, and in the past at Prince of Wales and Sydney Kids, we used to be able to look at all the scans done in a day. And I can tell you, if I looked at all the CT scans or all the MRIs done in a day, to look at head shapes, I would see at least 1 in 20 adults who had a significant plagiocephaly by measure, even if they obviously didn't have a major issue, and probably about 1 in 15 with significant brachycephaly, and that was usually culturally based. So most of them are mild. Children generally are flatter. So children up to the age of 2 years are flatter than the average adult. So the mean cephalic index in adults, we would like to be between 0.74 and 0.85, but in kids, I will happily accept a cephalic index of 0.9. And that's because your skull tends to grow backwards for longer. You tend to stop growing laterally and you grow backwards. And we see that quite often. And brachycephaly usually will improve by itself. And only about 1% of the kids with brachycephaly will stay clearly brachycephalic. And even those guys, those Macedonian guys, when you measure their head up, they look flat, but their cephalic index is often okay. High end of normal, but okay. So usually if you have a kid with a really weird, obvious deformation, they've had an obvious cause. So they're a twin pregnancy, they've been crammed, there's been oligohydramnios or something in utero. They've had a really bad torticollis and they're a floppy kid. There's often really obvious causes. And neonates, of course, because if they're very sick in the neonate and they've had problems with movement, they will be they can get very out of shape. The main differential diagnosis of positional plagioccephaly is Landroid-synostosis, which is extremely rare compared to everything else, but it's easy to miss. So it's good to know the different findings. So postnatal development is important because you're basically up to about 4 months of your age is the prime period of skull deformity. You know, kids are blobby, they don't move, you put them in bed, they stay where they are. If they like one position and they sleep well, they're going to get a flat head. Now, if you end up in NICU, of course, you've got a much longer time when you're outside facing the forces of gravity and lying down, and you've got a longer time to get out of shape. And parents usually start noticing these things usually 3 to 4 months of age. So often parents are so exhausted, they don't see anything in the first 3 months, and suddenly they wake up one day and go, oh my God, my kid's head is really abnormal. And it often makes them feel as though it's happened out of the blue. So the main risks for deformational things are either in utero, and we do see kids who might have been breached and something's been stuck on their head, have a bit of an asymmetrical head, or they've been engaged for a long time, intrauterine crowding, or their first child. Everything that twin pregnancies are another example. Those are a small percentage of the kids we see with deformational plagiocephaly. And by far and large away, and this group increased by 700% between when we started the helmet clinic and when Back to Sleep really came to the fore, and we saw a lot of postnatal deformational plagiocephaly. But the reason why you get it is anything that stops you moving will make you line your head more, you'll get more of a deformation. So being less than 4 months of age because you don't move, having a torticollis is a real common thing. My second most common, almost equal to torticollis, is kids who are good sleepers. They lie back, they put their heads back, go to sleep. Little boys, boy, they can get bad brachycephalies. Anything that restricts their movement. So kids who are on hip spikers, and if you have low tone, you're floppy and you just can't move yourself. So they're all the major risk factors for deformational plagiocephalies. And of course, torticollis is important for you guys because if you have a kid who's had an instrumented delivery, they're a lot more likely to get something like a torticollis. And so they've got a higher risk for getting a positional plagiocephaly. And if you know your kid, the kids that you have delivered or have been involved in their delivery have had an instrumented fusion, it's good to look for torticollis because if you get onto that early, you'll fix a plagiocephaly well before anybody notices anything. So it's very good for prevention. So when you're looking at these kids for examination for positional plagiocephaly, you want to look at them and see if they look odd. And now you just want to exclude that they don't have some syndrome. Typical of anything, I'm sure you all know, if you don't see it the first time, you just don't see it further on. So you have to look at them and go, do you look odd? Do you have a syndrome? When you've excluded that, you're looking at overall head shape. So you're looking for the rotational, a rotational sort of look where they've got a parallelogram picture or where they've got a flat head. And usually these people, when they've got a parallelogram picture, one ear is forward, everything's moved forward on one side and looks displaced in comparison to the other side. And that's very typical of positional. So these are the positional shapes we usually see. So the middle symmetrical one is, of course, a normal shaped head, but brachycephalic heads are very flat, and scaphocephalic heads, which can be positional if you lie kids side to side, can also be positional. Positional scaphocephaly used to be very common from ICUs because, 30 years ago, kids were often laid on their front and turned side to side. And it's still a bit of a party trick with patients where I can say to somebody, oh, you were premature because I've looked at their CT scan and they've got a long, thin head. And they go, how did you guess? And they've got long, thin heads. And of course, it's got a skew-shaped plagiocephaly. That's the other thing you look for. You want to measure their head circumference and you want to feel for a fontanelle. That's probably, you just want to check those things just to make sure the heads are growing, make sure the fontanelle's open and there's nothing else funny going on that might indicate raised intracranial pressure. Just a note on the head circumference, just so you're aware, a round head has a smaller circumference than an oval head with the same area. So I always say to patients, if their head is changing shape as they're growing older or with helmet therapy in the appropriate way to the way the head is developing, I reassure parents often about their head circumference going down or going up, depending on what it's doing. You also want to see where the vertex is, and with brachycephalies, I'm sorry about the drawing, the one on the right's terrible, but you often have a very sheer drop at the back and barely any occipital bumps, and it looks like goes straight up from the neck, and the vertex is really posterior, so it looks really abnormally posterior. So you want your vertex to be just above and behind your ears, and that gives you a nice looking shaped head. And most kids will then grow out, even they might look very flat, they tend to grow out from the occiput and slowly round out, so that vertex stays the same, but they push out down the bottom and slowly round that out. So the key thing in deformational plagiocephaly is if you look at a kid's head and you can see only one vector, so one area of pressure, and you can imagine where that's done something, then it's going to be a deformational. So in parallelograms, you've got head pushed forward from the side. You can also get them pushed across, so they can look like they've pushed their head from one side to another and the other ear is not very much pushed forward, so you get this splaying. And with brachycephaly, you just get a splay from the back, and that's very typical. You can get banana shaped heads even. So when you've got a bad scaphocephaly, sometimes when a child lays on its ear, that they're laying on that petrous temporal bone will bend the whole head around, and that's still a one vector. So it indicates a really bad deformation, and we do see these occasionally. So really with deformational plagiocephaly, early recognition is really the key. Early head turning is a key. Early physiotherapy, and so recognizing those kids who have had a traumatic birth or who aren't moving or have a bit of low tone or are stiff for other reasons or don't move for other reasons, get them into physiotherapy early and you will prevent nearly everything. Helmet therapy, I might run the helmet clinic, but nearly every child, if you leave them, will improve themselves. Helmet therapy does work if you put them in early enough. But if I saw every child at 5 months with a plagiocephaly I put into helmet therapy, all these kids be wandering around with helmets, and the vast majority will get back better by themselves. So I prefer seeing them between the ages, hopefully seeing them by 6 months and seeing if they've got signs of improvement, seeing how bad they are, and only putting them in a helmet if they're really badly off, or if they've got something that's going to prevent them getting better themselves, like they're still in a hip spiker. So CRANEOSINOSTOSIS. So you can sort of prevent deformational stuff. Your roles are really important for helping to prevent that and being aware and sending parents down making parents aware before they just wake up at 3 months and go, fuck, this kid's head is terrible. But craniosynostosis is a bit different because it often is really hard. It's not really necessarily very obvious at birth. So with craniosynostosis, there are a couple of different sorts. The type that I'll talk about mostly today is primary synostosis, because secondary synostosis tends to happen at later age groups, and it's associated with things like hypophosphatemia and weird metabolic disorders. You can get funny head shapes. If you've had sort of a stroke in utero and your brain's not growing, you can certainly get a funny head shape. And then the primary craniosynostosis are divided into single sutures and multi-sutural synostoses. I will say for the secondary craniosynostosis, some of the weirdest shapes heads I have in kids are kids who've had IVHs they've been prem, had an IVH, had a shunt put in, and they've got a lot of loss of brain and sucked in from the shunt, and can cause some pretty weird head shapes if you're not lucky. So synostoses are mostly classified into syndromic and non-syndromic, and this is where they're single or multi-suture. And we'll go over these, but they tend to be, of course, the syndromic types, because they involve more than one suture, tend to have much more significant long-term effects than the non-syndromics, which are usually single suture. So the typical single suture synostoses, we see sagittals down the bottom, metopic on the left, and unicoronal. They're our most common single suture synostoses. These are isolated abnormalities. They're usually kids who don't have any other issues. It's got a low risk of raised intracranial pressure, and that's probably even lower than we really expect. So when you look at some of the more recent studies, you can read, I've read between 15 and 30% in the long term, but it's really not that high. And operating early can hopefully mitigate that to some degree. These are easily diagnosable without imaging, and for a very long time in the craniofacial clinic, we simply haven't done CT scans. And we're doing them more now because we've had a recent Canadian guy working with us, and he really likes CTs, but I do worry about using CT in this age group. It has been useful though, because I see the helmet clinics, I see all the positional plagiocephalies as well as the craniofacial kids, and I'm used to diagnosing a scaphocephaly that is positional versus a scaphocephaly that is a sagittal synostosis. And to really clarify that, I've had to prove that to this guy by CT scans in these kids, because he really likes to prevent somebody having an operation for no good reason. These are usually somatic mutations, just local mutations in the area of the suture, and they're uncommonly germline mutations, but we do have some families where they clearly have sagittal synostosis, so they are germline mutations, usually in FGFR and a couple of other sort of growth factors. These may have subtle cognitive impacts, and there's increasing evidence. I'm very sorry. I apologize for that. There's increasing evidence for some cognitive impacts, probably most importantly in later development and in executive function and behavior and later in life, than significant IQ impacts. And there is some really soft evidence that suggests early surgery is better than later surgery. So the synostoses, unlike the deformation plagiocephalies, these are the shapes you can only create by there being two vectors. So, to get a metopic synostosis, you have to have a vector from either side of the forehead, from unicoronal, from front and back. They pull in on one side rather than move like a parallelogram. And same with the sagittal. Now, while the scaphocephalies can be positional, a sagittal synostosis works by restricting lateral growth. And this is effectively my concept of vectors is essentially just a reflection of Virchow's law, which is when you've got a suture fusion, the skull will expand parallel to that rather than perpendicularly to that. So as I said, these things can usually be very easily diagnosed by features. Now, the most common form of sagittal synostosis, because there are a couple of variants, is a typical scaphocephaly with frontal bossing and a very bullet-shaped head, pointed and narrow posteriorly. They have a very anterior vertex. And so the thing that makes them cosmetically look really weird is that vertex being forward. So if you've got a scaphocephaly where your vertex is in a normal place, you just don't look as weird. And you can have quite a bad sagittal synostosis, but not look bad. And, you know, these features are very easily seen in the X-ray on the top left and in the 3D reconstructions of a CT on the bottom right. Sagittal synostosis is best seen from both the side and from above. And you can see, and sometimes you will see narrowing, when you look from in front, you will see narrowing toward the top. So they've almost got a slight peak, almost like a superior trigonocephaly. Not never quite that, but they can sometimes say that as well. Metopic synostosis, of course, is trigonocephaly, and when you've got a head with a triangular shape and a really pointy forehead, this is what it is. I've never seen anyone have another diagnosis other than a metopic synostosis with this head shape. So even in the syndromic cases, you don't tend to see a trigonocephaly. So this is nearly always a single suture metopic synostosis. They have a very pointy head. They look as though somebody's their eyes are close together and it looks as though somebody's grabbed them at the sides, at their lateral orbits, and pinched them in. And you often have dents at that point. And if you look from above, you can see the cheeks easily beyond the eyebrow. Often the fontanelle is different shapes. So in a sagittal synostosis, you might find that you've got a fontanelle that's pointing forward and with the metopic remaining open a bit because the sagittal's closed. And you see the opposite in these, where it's not reflected in the bottom picture, but it's not uncommon for me to feel a backwardly pointing fontanelle with a very flat front. And I find often they don't necessarily look as bad physically as they do on a CT. And when you do CT, these things look really terrible. And we recently operated on a kid that thought, oh, you don't look that bad. I think you'll probably get away without it. But when we did the CT, it was really, really terrible. And as mentioned before, you really need a trigonocephaly for it to be a proper metopic synostosis. Metopic ridging without a triangular shaped head is not going to be an abnormal fusion. It's going to be the metopic fusing by itself as it should at that age. Unicoronal synostosis is about equally common in our group as metopic. It's described often as the second most common, but we see probably marginally more metopics than unicoronals. This is where one coronal at the top is fused. It pulls that eyebrow back. It often causes facial scoliosis, so the face is pulled around. And the other thing it causes is sometimes the base of skull is pulled around too. So when you look at the base of skull on the CTs, you can see it's very curved at the base. Very typical finding is a harlequin eye on a skull X-ray, and on the bottom left, you can see that the right eye, the sphenoid really raises up and doesn't come around to close the orbit, and that's very typical of unicoronal synostosis. And you can see the opposite on the 3D reconstruction below. And you see these best from in front, where you can see that eyebrow pushed back and the nose curving on that side. As I said before, lambdoid synostosis is very rare, and it does get confused with plagiocephaly. When I was with positional plagiocephaly, when I was training when I was a young person, one of the bosses I worked with always operated on lambdoid synostosis, and undoubtedly he was operating on deformational plagiocephaly. I remember seeing my first one of these in rooms. I'd been reading a lot about lambdoid synostosis and what the features were, and when this kid came in, it was blindingly obvious. They often have very asymmetrical skulls from in front, and they can often look like Mr. Gumby, where one side rides up on the other compared to the other side. They maybe look plagiocephalic from above, but when you look at them from the back, you can see their skull base is really uneven. Often the ears do not meet horizontally. Now, you've got to be careful. If you've got one big ear and one small ear, it might look like one is lower than the other, but you can usually see the whole skull base is lower, and you should have a large mastoid process on that side. A proper lambdoid synostosis, you will have a ridged lambdoid suture. It won't be indented in. An indented lambdoid suture means that it's restricting where the bone's growing out on the other side, and that's an improving brachy or plagiocephaly. And the other thing you get is under that ridge, you often get an indent, and it's often a really obvious indent. And when you feel it, it's really quite stark. And these kids will often end up with problems with their posterior fossa being too small and the risk of Chiari malformations later in life. So management of these is usually surgical. It's really mainly for cosmesis. I get my head around it by thinking I'm maybe doing something for these kids for future ICP, because that's, but they will get teased. They do look pretty weird if you leave them alone. And there's a vast variety of operations. So for sagittal synostosis, at one stage, I could name a hospital in Australia and we all did different procedures. Though increasingly we're doing endoscopic strips with helmets, and that seems to be working just as well as things like the standard bigger procedures, pie procedures, or even the springs. For other things like unicronal and metopics, we're often doing bifrontal orbital advancements, or if you've got the posterior problems like lambdoid, you're pushing it backwards. And it's usually, early surgery is usually done for the strips, and we do this mainly for sagittals. We do some metopics. We're not sure our results are good enough to say that's true. And if we see a very early lambdoid, a strip can be useful. It's possible, and there's soft evidence, as I said, that treating these early at before 4 months of age may have some beneficial effects for later cognitive changes. And this is usually quite minimal surgery, so much lower risk of needing a blood transfusion, a quicker hospital stay, and so forth. Later surgeries usually refer to the bigger ones like metopic, unicronal, and lambdoids, much higher blood loss. And we use it for the failed sagittals or people who present with late sagittal synostosis. And the diagram on the right shows the Melbourne procedure, that was grouped down in Melbourne, of course, and it shows what a jigsaw puzzle we have. So my job as a neurosurgeon is essentially joining the dots, cutting bits out, and the plastic surgeons put the puzzle back together. Of course, you don't need surgery. And this guy is a guy who runs a big multi-million-dollar company in the United States, and he has a clear sagittal synostosis. He's grown up without surgery and is perfectly fine, thank you very much. So you may never get a problem. You might get some problems, but you may never get a problem with a single synostosis. So multi-sutural synostosis, I will go quickly. Sorry about this, guys. You don't often diagnose them early, but you can diagnose them early, and they're often very typical cases. These are syndromal. These fusions don't involve the convexity sutures, they involve everything. So you get much weirder findings. There's a much more significant risk of raised intracranial pressure and the associated cognitive issues. And also lots of other issues come with these, like poor airway function, Chiari malformations, and syndactyles. So just a note about facial bones, there's lots of them, and they should not fuse before adulthood properly. You've got your whole childhood to really form your face. And so if you have one of these syndromes, you're going to get a really odd looking face. So the most common ones are listed here, and these, as noted before, tend to have germline mutations. You see families of people with Cruzons and things like, not so much APITs because they're often more cognitively disabled, but sort of Wenke and Seychelles-Chotzen, fathers had an operation or mothers had an operation. I've got a family where we've got grandma, 3 children and all of their children, all with Cruzons. And these different twist and FGFR mutations are important, all of these. So they do have some variations and as described here. So they rarely present early. And when they do present really early, they're often the worst ones, like a Pfeiffer syndrome or a Kleibach or a Cloverleaf skull. And these kids have really small skulls, very poor orbits, so they get proptosis. They usually have severe respiratory dysfunction due to maxillary fusions and hypoplasia and poor eye protection. And we've had a couple of these at Royal Women's since I've been there, where we've had an early bad Pfeiffer's, and these children have been allowed to die because their prognosis going forward is so poor. The other ones you can diagnose early are those who have clear, obvious abnormalities. So APIT syndrome can commonly be diagnosed early because it's very commonly associated with syndactyles and funny ear things. So the head may not look that bad when they're young, or you might not be able to tell because they've got lots of bruises over their head, but the syndactyles and the funny ears are really obvious. And as the faces and heads form, you really get funny shaped heads. So these are the sorts of common ones that we see, that we really see more obvious later in infancy. So while they might not look too bad initially, kids with wide spaced eyes, such as frontonasal dysplasia, often people look and go, aren't they cute? But as they get a little bit older, even in 2 to 3 months, you see that it's really quite weird. Croissants very typically have slightly buggy eyes and slightly hooked nose, and it's a very typical finding. And you will see people wandering through the streets. You go, you're from a family with croissants. So again, this is really complex. The management is multidisciplinary. It involves us and plastics doing a lot of the operations, but the ophthalmologists do separate things, ENT do separate things, max packs and dentists are really important as they get older. We have the geneticists involved, speech path, social worker, and so forth. We really should probably have a psychologist with this lot because it has significant impacts for both the parents and the children. These kids need imaging. We need to do a CT often to see what we're doing and how to plan and to make sure they don't have significant problems like a Chiari. Genetic testing is really important, particularly important for them later in life. And these kids have planned and staged surgeries throughout childhood. So it's a pretty horrendous childhood for most of these kids. And this is just a typical case. So I've got a picture of a kid with the croissants on the left, and this is not this patient, but this girl who I've known for most of her life. This was her early CT when she was born. She has clear fusion posteriorly. She's widely open at the top and her head doesn't look that bad. And even her maxilla, if you look at that head shape, it doesn't look too bad, but she has significant problems and she needed a BFOA, which is bifrontal orbital advancement at 15 months of age. You can see her skull just hasn't grown on top very well. So while it's been pushed forward, it's looking very odd at the back. She needed a Chiari malformation for a small posterior fossa when she was 15. And then at 17, she had a maxillary expansion. So she had some expanders put on her maxilla and her whole maxilla pulled forward. And you can see in the x-rays, the difference where her maxilla is and her upper teeth are well behind her lower teeth. And her eyes look buggy on the left x-ray, and the later one you can see how much further forward her teeth are, and it's pulled her face into a much more normal position. This is really important for things like breathing. These kids have really bad problems breathing, they get bad sinusitis, and it just helps them with opening their airways as they get older and making them just look a little bit more normal, and their eyes being less buggy and protecting their eyes. And that's probably the main issues. So overall, the important stuff you guys need to know is that you see lots of odd-shaped heads. Most of them are fine. Deformation usually occurs in the first 4 months if it's going to happen, and if you can notice it early, you can fix it, you can get onto it early. Otherwise, I'm going to put them in a helmet. Synostoses are very typical. They often have typical facial and head appearance, and the more synostoses can be recognized early. So you probably won't with a lot of them, but if you do see some of these features, you'll get on top of it early. But they'll have lifelong management. Thanks.
Thank you, Erica. This was an amazing summary from, the most commonest stuff of deformation into the most severe end of the spectrum, which indeed everybody would easily recognize. And so there's time for some questions. Please put your questions into the chat box. There's a couple of questions there. And I can imagine, the question is going to be, because there is this overlap in the gray zone between what is normal and just goes away and doesn't even need referral versus I'm not so sure. And when I listen to your talk, actually the hardest part is maybe during the NICU stay or their first week to determine which one is going to go which direction. So the questions are going to be on, how do we do that? And you showed some good examples of that physical exam, how to do that well. But for instance, Rajiv has a question, if we then do imaging, what kind of imaging? You gave your opinion and ideas a bit about it, but can you tell us a bit more? What would you what kind of imaging would you suggest?
Most of the time, for a long time, we did virtually nothing because you can diagnose these things without imaging. And I do think you do want to limit things. I think with simple sagittal synostoses and stuff like that, you don't necessarily need to do anything. They are diagnosable. But ultimately, it's probably, if you're going to have to do something, you may as well do a CT, because you do want to check other things. I'd agree with Rajiv's statement that most people wouldn't do a skull x-ray. I very occasionally will do skull x-rays, mostly because you get some families, we've got a positional plagiocephaly where they are so concerned that there's a fusion going on. You almost need to do something. And sort of a simple single AP x-ray is enough. You don't have to do all 3 or 4. You do a simple AP and go, look, there's the lambdoids, they're both there. Don't worry, it's fine. So I'd agree for anything sort of more severe that we're seeing in craniofacial, a CT is far better than anything else. We do see lots of ultrasounds, but I can't read ultrasounds and they're often incorrect. And often we can diagnose it anyway, so it doesn't matter.
So you touched on this, and I want to continue on that a little bit further. When you say now the people who are coming in as a referral, they are people who really have maybe read something online and have an opinion, and they find it difficult to find the difference between what's normal and what's not. So is that a growing group of people?
Oh, it's terrible. I actually have real problems with the helmet group, the positional plagiocefalies. I see more anxiety in that group than anything else. I see people with brain tumors, and they seem to, with kids with brain tumors, they seem to cope with it better. And there's a lot of, I think it just reflects population. So I'll see, and I find it impossible to tell what a family is going to be like. So I'll see a child and I'll say, this doesn't look too bad. And then I'll have one of the parents, and it doesn't matter who it is. It could be the grandmother going, no, it's terrible. I've got some trouble. You need to do something. And they can have a normal head, like an almost normal head. Whereas, other people who go, oh, look, I just left him on the floor. I'm fine. I don't really want a helmet. Impossible to tell. But the degree of anxiety I see is completely disproportionate to the level of the problem. So if we can get onto these things early, and we have seen it in neonatal intensive, we don't see sort of those long thin heads like we used to. And actually, I think overall neonatal intensive care do a very good job with head shape, because we don't see a lot of deformation.
Yeah, agree that. We're doing the head shapes, yes.
Yeah, it's actually very good. It's certainly improved even in my lifetime, but yeah.
There's a question here from Julia about referring
Yes.
of plagiocephaly and microcephaly in the craniofacial clinic. So because she said, you can actually wait and see the progress. And so should we refer late or should we refer early?
Look, I think if it depends on the anxiety of the family. I see, look, there's nothing, often it's really more about reassurance. So if you've got a kid with a plagiocephaly that you think is just positional, then referring them late is more for a reassurance of the family that things are okay. Because, a lot of people, by the time you get to say 22 months with a positional plagiocephaly, there's hair and people are going, it really doesn't look so bad anymore. But if you think it's a fusion, there's no problem in referring late. We do operations. We have done operations on 3-year-olds, 4-year-olds where we have to. And if it's something bad enough, it's worth seeing in the clinic, there's no doubt. Microcephaly is a bit of a different thing, because microcephaly is often more about, if there's an obvious fusion, it's obvious. But if it's microcephaly and they've got a normal looking head, it's often more about brain growth. And I probably think if you're seeing somebody with microcephaly, it's probably worth running them under an MRI. And just getting imaging just to see what's happened with the brain development, because you often see quite significant strokes. And weirdly, I see lots of kids who have half a brain missing and their head is a normal shape. It might be small, but it's normal. And you'd expect it to be kind of flat on one side. And if you measure it out, it is a little bit asymmetrical, but they don't necessarily look asymmetrical. So you can't tell what's going on inside just from what's outside. So I think if it's microcephaly, I'd get an MRI.
Yeah. I think that will be the recommendation from the pediatrics as well for microcephaly in general sort of sense.
Yeah.
Abjad, sorry?
Always happy to see them though if we have to. It's no problem.
Abjad has a question about what are the risks of vision problems and hearing defects and developmental abnormalities in dentures with the single suture fusion?
With single suture fusions, really not much at all. I mean, they don't have a height. So things like visual defects and hearing defects are much more going to be related to raised intracranial pressure. And the incidence of raised intracranial pressure, when you look at it in the literature, is far lower than we really think it is. So as I said, we've had some reports up to 30%, but really in the more recent literature, it's much lower than that. So as they don't have a high risk of raised intracranial pressure, they're not likely to have major issues with vision and hearing. Having said that, they all go and see our ophthalmologists and our ENT people when they're in the clinic, and we check it out, but they don't often need much input. Dentation, again, not much, because these are often fusions that affect the convexity and those sutures and not the other sutures. The syndromic ones tend to affect not only the convexity bones, but also the base of skull bones and the facial bones, and it's much more complex genetics. And that's where you get the real problems with development and dentition and raised intracranial pressure.
I have a last question, I think, before we sort of close off, I guess, unless some more questions pop up. You told about the importance of just looking at the head shape. Sure, also feeling. Are there apps already on the market where you take pictures and you go around from the top?
I don't know. I just look at them. But I've been lucky. I'm lucky that I have really spent a long time seeing everything. So I'm used to looking at them. But it would be a great opportunity for somebody to make a nap. I'd happily help somebody do that if they wanted to, but it would help a lot, because I think really once you've got those features, it would put a lot of people at ease if you can look at those things. And yes,
of those features, of the numbers which he then creates of size and shape, there are numbers, I'm assuming, which you go like, now I'm more concerned or now I'm less concerned.
Yeah, certainly with cephalic index, if I have somebody with a cephalic index that's lower than 0.7, they've got scaiphocephaly. And usually in the adult population, that's under 0.74. And even, you know, some kids at between 0.7 and 0.74, they've got a proper fusion. So if they're long and thin, yes. If they've got a very flat head, I find with that's often positional, but a greater than 0.9. And I use those numbers. I don't like the helmets. I don't think they're that useful. But I do have to force myself into having some sort of limit as to when I would use them. So anything over 1, a cephalic index of 1, I would consider using a helmet for. And that very much, again, depends on whether the family are keen for a helmet. But if they're showing signs of improvement, I'd just leave them, because only about 1% of brachycephalies will stay brachycephalic.
I think there's one last question from, again, about referral. Yes, it's more questions about referrals. One about suggesting early versus late, which I think you already answered.
Early for monosutures, definitely, because I think they have a smaller operation and with really reasonable results with early, and we can get them assessed. So I prefer an early referral, definitely.
And the second question is related to helmet fitting without referral.
Yeah, look,
where do we stand? Huh?
Well, it's undoubtedly a thing. I mean, for a long time I was asked whether I would start a helmet clinic outside, and I don't believe in mixing business with pleasure. And I don't, I just thought that I didn't want to have anything that would make me put people in a helmet when I didn't think they needed to be in a helmet. They do provide a service. There's a lot of people out there, and this is a very cosmetic environment nowadays. And I think it serves to have some sort of study as to how cosmetically aware a family is or a parent is, and how worried they are about their child's head shape. Have they had cosmetic surgery themselves? I suspect there's a good correlation there. And I think those clinics are actually quite good for those people where they don't really need a helmet, but they're really happy to spend $2,500. However, I've seen 3 patients now who've gone through the clinics without a medical diagnosis. A couple with a medical, without, have seen somebody who's worked in that clinic, and then they've ended up with a helmet and they've actually got a lambdoid synostosis. So I think the biggest problem is them not being properly assessed. And while that pickup is really low, you don't want to be putting somebody in a $2,500 helmet when an early operation at 4 months for a lambdoid synostosis strip may be all they need and help minimize the problems for Chiari later on. So yes, I have seen a few of those, and I think that's my biggest concern, is that they're not assessed properly.
Look, again, thank you for this wonderful overview of this topic, which we see commonly, but the questions are always there, every patient we have. So this was a fantastic overview. Thank you so much, Erica, for presenting. Thanks, everybody, for attending, and we will be back next week.
Thank you very much, Kurt. Take care.
Recording stopped.